focus the talk on the new medical therapies and devices that we have available to these patients. And then finally, I'm going to discuss timing for referral for advanced therapies. I will give a little bit of a glimpse as well for the applicants on what we have to offer here in heart failure for the fellowship and in terms of research as well. So heart failure is an epidemic. There are 6.5 million Americans currently afflicted with this disease, and it is projected to go up to about 10 million by the year 2037. It is a disease, and this is including HFpEF and HFrEF, which I'll define for you as well, but this is a disease that increases with longevity, and so we continue to project an increase in the numbers. It accounts for almost 2 million outpatient visits and greater than 1 million admissions per year. And as we all can attest to, and CMS continuously reminds us of, it accounts for a very high readmission rate. So 25% of patients with heart failure are readmitted within 1 month and 50% within 6 months of discharge. And heart failure also accounts for the vast majority of post-cardiac surgical and percutaneous valvular admissions. So accounts for a lot of the admissions there. It comes with a high mortality rate, and unfortunately greater than 50% of patients with heart failure die within 5 years of diagnosis. And that's why it's really important for early referral and discussion of advanced therapies early. And, you know, the bottom line is here, it's high, and the estimated total cost of heart failure in the US is $32 billion. So I'd like to just take a moment to define, you know, the population I'm going to talk about today. And so, you know, we've heard of HFrEF and HFpEF, heart failure with reduced ejection fraction, and heart failure with preserved ejection fraction. The ACCHA guidelines in 2013 defined this as HFrEF as less than or equal to 40%. The European Society of Cardiology also uses a cutoff of 40%, and greater than 50% is considered HFpEF. Now, in between that range, they just have different nomenclature, but it's the same thing. So it's either HFpEF borderline or this new term in our alphabet soup of heart failure, which has become popularized by the ESC guidelines, of HFmrEF, which is heart failure with middle range ejection fraction. So a lot of new fun names, I guess, but what we're going to really focus on today are the HFrEF population. And then, you know, we really should define the stages and classes of heart failure so we can understand the prognostic implications in these patients. So patients, we've heard, you know, many of us have heard of, and many of you have heard of the NYHA classes. These have been around for a very long time. And these are basically describing symptoms in heart failure patients. So it goes from 1 to 4, 1 being asymptomatic and 4 being symptomatic even at rest. The arrow on the right depicts that patients can go up and down these classes. And that's kind of our goal in treatment, is we're trying to get patients to go from a 3 to 4 to a 1 to 2. And when we get to 1 to 2, then we're pretty satisfied with that, even if the ejection fraction has not completely improved. But the stages are newer. They've been around for a couple of decades now, but they're newer than the NYHA classes. And these define patients as anywhere from, you know, no structural heart disease, but risk factors for heart failure, which is A, all the way to the refractory heart failure patients in the D classification there stage. And when a patient, you know, gets to D, that's when we really should be thinking about advanced therapy options like LVADs and transplants. The important thing about the staging to understand, and you can see with the arrow there, you can only go in one direction. So, you know, I really try to emphasize this with the fellows and residents that rotate with me, that we should try to think about what NYHA class of patient is and what their stage is, so we can really think about what therapies we want to use and what their prognosis is. And so once a patient is a C patient, meaning they've had symptoms in the past or currently, you can never go back to B. And if you're really going to call patient D, you really are thinking this patient needs advanced therapies. And why this is important is depicted here on the right, and you can see a significant decrease in survival in the patients as they go to the higher stages. We're going to focus today mostly on these symptomatic classes and the stages C through D patients. So I'm gonna segue over to our newest drugs that we have available. But a talk about heart failure and drugs would be remiss without the token pathophysiology slide with a lot of arrows going in all kinds of directions. So I tried to make this, I found one that was not so difficult to understand, I think. So we'll go through this piece by piece, but just starting on the left over here, you can see that a simple diagram of an index event that happens. So whether it be a myocardial infarction or a viral infection that leads then to some damage and dysregulation in myocyte gene expression, which then leads to apoptosis, microcirculatory defects, decrease in contractile function. And so that starts here, and you get a depression in the left ventricular performance and reduction in cardiac output. The body tries to compensate, and so, initially increases the heart rate to make up for the decrease in stroke volume so that cardiac output can be preserved. There is a transient, albeit not a persistent, increase in contractility. And then there's some changes that happen actually to the geometry of the heart and the remodeling that we do not like to see, including hypertrophy and then dilation and an increase in LVEDB. There is a revving up of the adrenergic activity and the renin-angiotensin-aldosterone activity, and basically the neurohormonal responses that are trying to compensate for the reduction in cardiac output, but we do not like these responses, and we try to block them with our beta blockers, ACE inhibitors, ARBs, spironolactone, or MRAs, our go-to medications in the guideline-directed medical therapy of heart failure patients. And the reason we want to block here is because what happens is with these neurohormonal responses, we get an increase in renal sodium and water retention, systemic vasoconstriction, that leads to further increase in preload, afterload, myocardial hypertrophy, ischemia, remodeling, and then more depression of ventricular performance. And so you end up with this cyclic nature, this vicious cycle of chronic congestive heart failure, and this poor heart that's working really hard to breathe. So looking at the drugs here, digoxin and diuretics, and I'll mention these as well, these are medications that may help with symptoms, but not really with mortality, whereas the neurohormonal blockade agents are the ones that have been proven to help in terms of mortality. So we'll take a break here from the pathophys slide and just ask a question of the group. So hopefully this will work. Which of the following agents has survival benefit as a replacement rather than an additive therapy in heart failure with reduced ejection fraction? So replacing one of the original medications. Is it the ARNIS, the angiotensin receptor neprilysin inhibitors? Is it the mineralocorticoid receptor antagonist, MRAs? We like our alphabet soup here. Is it the hydralazine isosorbide dinitrates? Is it the loop diuretics? Or is it the sodium glucose cotransporter 2 inhibitors, the SGLT2 inhibitors? I'll give a moment here to gather some responses. I don't know how many people are here, Artie, but do you think that's...
Yeah, we can go ahead and end the poll.
Okay, great. So if I click there, does that show to everybody? So most people got this right. The answer is the angiotensin receptor neprilysin inhibitors, the ARNIS. That's great, as the first medication that came out as a replacement therapy. So I'm going to just... Oh, did the results show? I don't know if they showed here.
They should have.
Okay, I'm going to just close that. So this slide here just shows the drugs. On the left here we have kind of the basic drugs that we use in our guideline-directed medical therapy tool belt. The medications that have been shown to reduce mortality in HFrEF, the ARBs, the ACE inhibitors, beta blockers significantly decrease the risk of mortality, and the mineralocorticoid receptor antagonists, based on the original trials, including SOLVED, CHARM, Copernicus, MERIT, CIBIS, and Rouse and emphasis were for the MRAs. Consensus was the original trial that looked at enalapril as well, compared to placebo. And the ACE, ARB, ACEs or ARBs and the beta blocker are really kind of the basic medications we use, and then the MRAs are the medications that are additive. And so based on, what the data we had, based on these studies, the 2013 guidelines, heart failure guidelines had that for heart failure with reduced ejection fraction, again, 40% or less ejection fraction, any class, so even asymptomatic patients, it is standard of care for these patients to be on an ACE or ARB and a beta blocker. So whether they're symptomatic or not, and then you can add a loop diuretic if they need it. Doesn't improve mortality, but can improve symptoms, as we all know. You can add the hydroiserdil combination in patients who are African American and NYHA class 3 to 4 for mortality benefit based on the AHEP trial. And then we can add the MRAs, which we frequently do in patients who have symptoms and do not have a potassium and GFR that would preclude the addition of that medication. And this is a timeline that kind of looks at how the medications have come along in the heart failure world. In the 1980s, really the only thing that was available for patients was some symptom management with digoxin and diuretics, but not any mortality benefit from those medications. In the 90s came along the studies that showed the effect of the basic guideline-directed medical therapy we use now: beta blockers, ACE inhibitors, ARBs, MRAs, isosorbide, and hydralazine in certain patients. And then there were, a lot of device therapies that came about, which have really changed the world of heart failure and improved mortality in these patients, including ICDs, CRT, LVADs. But there was a big hiatus in terms of drugs that were available until about 2010, when a medication called ivabradine came out, which I'm not going to actually focus on today because this medication may be helpful in terms of heart failure hospitalization, which is good, but did not meet the primary endpoint of heart failure hospitalization mortality in the study. But really, after about 2 decades, we finally found a medication, which are the ARNIS, that could be a replacement medication and actually superior to the basic medication we use, an ACE inhibitor, which is what's compared to. And then finally, we have now in 2020 the SGLT2 inhibitors, which I will discuss as well as the newest medication out there. So I hope this slide doesn't age me, but I know that that this group is now popular again and has been in concert. But the new drugs that we have available are the ARNIS and the SGLT2 inhibitors, and I'll talk about the studies that look at these medications. So we'll start with the ARNIS. Another little bit of pathophys, but I think this will help summarize nicely how this medication works. So it is a combination drug. It includes valsartan and sacubitril. So valsartan over here on the left, we know that drug well, but it works on the angiotensin receptor, and that blocks basically the RAS system, and you get the downstream effects of decrease in sympathetic tone, improvement in blood pressure, decrease in fibrosis and hypertrophy and remodeling. So that is all great there. But the new moiety here is the sacubitril. So just to kind of review this, neprilysin is an enzyme that breaks down BNP. So sacubitril blocks neprilysin, and so you get an increase in BNP levels. So you might ask, well, isn't BNP bad? Why would we want to increase BNP? But remember, BNP is actually just a marker of badness in heart failure, in atrial stretch and volume overload. But it actually by itself can be a beneficial agent. So some may remember niceratide, which is a recombinant BNP that used to be used frequently in the heart failure population for symptom management and diuresis. So it has a natriuretic effect to it. This medication is no longer available, and in a large randomized trial did not show significant benefit in terms of outcomes. But it did anecdotally help in terms of symptoms. And furthermore, BNP actually has the downstream effects of improvement in sympathetic tone, aldosterone levels, cardiac fibrosis, and causes vasodilation through its effects in, it basically upregulates guanylate cyclase enzyme, which, a receptor, excuse me, which increases the concentration of cyclic GMP within intracellularly, which then leads to smooth muscle relaxation and vasodilation. In addition, neprilysin breaks down bradykinin, and bradykinin actually does have some positive effects as well, including natriuresis and increase in nitric oxide production, decrease in blood pressure. But it does have the negative effects that we know well in terms of what we've heard with ACE inhibitors, including the possibility of having a cough or even worse, angioedema. So that's one of the risks with this medication. So Paradigm HF is a study that came out in 2014 that really revolutionized the heart failure world. And, I remember it being touted as, causing a paradigm shift in terms of how we think about guideline-directed medical therapy. This study, at the time, this drug was called LCZ696. They didn't have a name for it yet. But it studied a little over 8,000 patients with HFrEF and symptoms, so class 2 to 4 symptoms. And basically randomized them to the ARNI treatment versus enalapril. And they used enalapril here as that was the original drug that was used in consensus. And the primary outcome was cardiovascular death or heart failure hospitalization, the composite outcome. And what was very striking here is that there was a 20% decrease in not only the primary composite outcome, but each of the components of the outcome, as well as death from any cause. And the number needed to treat here is very low in the low 20s. So in which of the following patients would you start or switch to sacubitril/valsartan? We can start the poll here, I think, Artie, but the A is a 49-year-old female with ischemic cardiomyopathy and EF of 30%, NYHA class 1 symptoms on guideline-directed medical therapy. B is a 36-year-old man with non-ischemic cardiomyopathy, EF of 45, class 3 symptoms on guideline-directed medical therapy. C is a 75-year-old man with non-ischemic cardiomyopathy, EF of 15%, class 2 symptoms on guideline-directed medical therapy. And finally, D is a 40-year-old man with non-ischemic cardiomyopathy, EF of 15%, with class 3B symptoms on very low doses of guideline-directed medical therapy due to orthostasis and a low blood pressure at 85 systolic blood pressure. I think we got a good number of responses here, so I'm just going to share that. And so most people got it right. And the idea here is that the patients who qualify for this medication are patients with a reduced ejection fraction, so again, 40% or less, and have to have symptoms. So the class 1 symptom patient in A would not qualify. And technically, based on the original ACCHA guidelines that included ARNIS, and it is for replacement of the medication after a patient tolerates an ACE or ARB. Now that's going to change most likely based on the Pioneer HF trial that we were involved in as well, which studied initiation of ARNIS in the acute decompensated state inpatient and did show a decrease in heart failure hospitalizations and was safe. So the most recent guidelines are actually currently being updated and likely will include that. The other thing of note is that the patients who are on ACE inhibitors have to have a 36-hour washout, so to decrease the risk of angioedema. And so, one, little tidbit is that a lot of the doctors now, a lot of the heart failure physicians are starting patients, even if they're a new diagnosis of HFrEF and they can tolerate the medication, and they're in the inpatient setting, we'll just go ahead and start an ARB right off the bat because you don't have to have the washout period. Get the insurance approval for the trade name Entresto, which is the ARNI, and then we switch them over to that medication. So I'm going to shift to the other new drug here, the SGLT2 inhibitors, and this is a nephron for the cardiologists. So very simple here, hopefully. So it's simplified for me at least. And we start with basically looking at this and where SGLT2s act. You can see 4 big red arrows so that there's no question of where they act, but right here in the proximal tubule. And what they do is that, there's a certain amount of glucose that's filtered through the glomerulus. The SGLT2 inhibitors act here in the proximal tubule in order to decrease glucose reabsorption, and so you get a glucosuria. And this is a medication that's based on these effects, or is used for diabetes. But how did it come about in the heart failure world? So the story starts out with EMPA-REG, which was a study looking at one of the medications in this class, DAPAGLIFLOZIN, and they're hard to say. So I'm just going to say EMPA and DAPA from now on during this talk, but that's the medication. And what it did, this study actually was a non-heart failure population of patients. It was a diabetic population, and they were looking for the whether or not this medication, EMPA, decreases the risk of cardiovascular events. And it did find the decrease in cardiovascular death, non-fatal MI, or non-fatal stroke, really driven by cardiovascular death, not really by non-fatal MI or non-fatal stroke. But what was interesting is that they found this very strong signal for a decrease in heart failure hospitalization, again, in a non-heart failure population. So then the question was, well, what about in the heart failure patients? And so that led to DAPA-HF, which came out last year. And this study was actually looking at patients with heart failure with reduced ejection fraction who are symptomatic with or without diabetes, and randomized them to DAPA versus placebo, looking at worsening heart failure or cardiovascular death, and found they did meet the primary endpoint and actually improved outcomes there, as well as the components of the primary outcome. And the findings were similar whether or not the patients had diabetes or didn't have diabetes. Actually, 55% of the patients did not have diabetes in the study. What was also important is that, the question was, well, what about the ARNIS? If someone's on an ARNIS, is that actually going to be significantly beneficial? And 10% of the patients were on an ARNI, and further subgroup analysis showed that there actually was benefit whether they were on an ARNI or not on an ARNI. This is an additive medication, not a replacement, but it is very beneficial. The other thing that was very telling about the study is about so over 90% of patients were on the basic medications in the RAS inhibition and beta blocker realm, but 70% of patients were on MRAs, which is very impressive for the studies. Most studies don't have patients on that much MRA. And so this led to the approval this year in March 2020 for symptomatic heart failure with reduced ejection fraction with or without diabetes for the use of this particular medication. It's probably a class effect, and so thereafter, a couple months later, this study came out, EMPEROR reduced, that looked at EMPA, and similarly found an improvement in the outcome of cardiovascular death or hospitalization for worsening heart failure. It did, when you look at the components, it really improved the heart failure hospitalization and but not cardiovascular death. But this was a sicker population, so they had lower EF on average and higher BNP, NT-proBNP than the DAPA population. What this study also looked at which was interesting, is the annual rate of decline in eGFR, and found that actually this medication decreases the annual rate of eGFR decline. And so patients with heart failure have a decline in their eGFR, but this slows down the rate of that occurring. So why do these medications improve heart failure outcomes? So there's a lot of questions about this. Initial thoughts were, well, maybe it just helps with heart failure hospitalization because of the natriuretic effect. If there's glucosuria, patients are going to urinate more, they're going to just feel better, and that decreases preload. But there's more to it than that. Actually, these medications improve endothelial function, decrease vascular resistance, and improve cardiac afterload. And also have been found to increase oxygen supply, decrease oxidative stress, decrease fibrosis in the atria and the ventricles in rat models, and decrease neurohormonal stimulation. And so ultimately have some effects on on LV geometry and mass as well. And these drugs are now being looked at in the HFpEF population. So the updated guidelines in 2017 did include ARNIS as a replacement medication for ACEs and ARBs. And like I said, they're currently actually working on the guideline update now, which we know the SGLT2 inhibitors will be added in here somewhere as well. So we look forward to that. I'm going to switch gears now and go over to our devices and talk about some of the newest devices that we have out there in the heart failure world. And I'm going to start with the CARDIOMEMS, which is our heart failure monitoring device, implanted by via a simple right heart cath by the heart failure physicians. And it is basically just a sensor that sits in the pulmonary artery. A patient lays on a pillow, pushes a button. Magically, we get these numbers that the heart failure nurses and doctors can look at that include PA systolic pressures, diastolic pressures, mean pressures. And the idea here is to be proactive and not reactive. And so what happens in patients with heart failure is that they get an increase in filling pressures first over here. And it's a long time before they actually start to show weight changes and symptoms. But weight changes and symptoms are very close to when they're about to be hospitalized. So classically, we have been, heart failure physicians and others have been targeting the weight change and the symptoms, the leg swelling, the shortness of breath, orthopnea, PND, etc., and the changes in weight. And then we say, okay, let's go up on the diuretics. But this is the point where patients start becoming more diuretic resistant, having, kidney dysfunction, etc. And then often we end up having to hospitalize them. So if we act here when the filling pressures rise based on the CARDIOMEMS reading, then we can prevent the patients from going to this side and prevent many hospitalizations. And several trials, the CHAMPION pivotal trial and the US post-approvals trial recently actually showed a significant reduction in heart failure hospitalization regardless of LVEF. Oops, that was fast. I'm actually gonna just not do a poll here, but I'm just gonna use this question to teach a point. But in which of the following patients would you consider for CARDIOMEMS? And the first patient here is a patient with HFpEF, class 2 symptoms, no hospitalizations for heart failure. The second patient is a patient with HFpEF, class 3 to 4 symptoms, recently admitted for IV LASIK strip. The third patient is a patient with HFrEF, class 3 symptoms, admitted to the observation unit for IV diuresis overnight. And the fourth one is a 40-year-old patient with severe precapillary pulmonary hypertension and predominantly right-sided volume overload. And the answer here, and the reason I just want to make this point, that patients need to have class 3 to 4 symptoms and a heart failure hospitalization in the past 12 months, not in the observation unit, to be approved for this medication. And any ejection fraction can benefit from this. And in fact, we've found it to be quite helpful in the HFpEF population, which classically tend to have more obesity, lower BNP levels, difficult to assess JVPs, etc., kidney dysfunction. And so it's been really helpful in that population in terms of targeting the right dose of diuretics in those patients that can be difficult to assess even clinically in the clinic. So now I'm going to talk about functional mitral regurgitation and how that has been targeted as a therapy in heart failure. So functional mitral regurgitation occurs when the ventricle is weak and dilates, and then you get a dilation in your mitral annulus. So that causes a non-coaptation of the mitral valve leaflets and mitral regurgitation. So the question comes about, well, is functional MR in patients with HFrEF merely a biomarker of severe LV dysfunction? As in, did the LV dilation just lead to this, and is that just a marker that the heart is very sick? Or does the mitral regurgitation contribute to worsening LV dilation and outcomes? Because mitral regurgitation can do that as well, or is it a combination of the two? And that's where the question came about of, well, if we fix this problem, are we going to actually help the pump? And so I'm going to talk about the studies that looked at this MITRACLIP. I'm going to start out with COAPT, but I do want to mention the other study that looked at this, MITRA-FR. So MITRACLIP therapy is basically a percutaneous device implanted into the mitral valve that basically clips the leaflets together in order to reduce, basically to undo that non-coaptation that's occurring and reduce the degree of mitral regurgitation. And the study that really was groundbreaking for this was the COAPT trial, where 614 patients with EF in the range of 20 to 50% and 3 to 4 plus secondary mitral regurgitation or functional MR, and symptoms, class 2 to 4 symptoms, despite guideline-directed medical therapy and CRT. And I really want to emphasize that piece, that they were on really good guideline-directed medical therapy and received CRT if indicated. And they were randomized to the MITRACLIP plus medical therapy versus medical therapy alone. And there was a very profound and early decrease in heart failure hospitalizations found in the group that received the MITRACLIP therapy. In addition, there was a decrease in death from any cause from the device therapy as well. And this study, when it came out in TCT, it actually received a standing ovation because of this slide here, which showed that they had 10 pre-specified secondary analyses, which this study met, MITRACLIP met in every single one of them, including, you know, death at 12 months, change in quality of life using KCCQ score, change in 6-minute walk distance, NYHA class, change in LVEDV, and mortality at 24 months. And in addition, there were very few, as you can see on the right side of the panel here, there were very few device-related complications. Of note, there were patients, out of the 614, 5 patients did need advanced therapy. So 3 patients received an LVAD and 2 went on to get a heart transplant. And so I think this is important because it's helped us as physicians in trying to treat these patients when we discuss whether or not we should put an LVAD in a patient or should we start with MITRACLIP. You know, putting in a MITRACLIP in a patient does not preclude them moving on to getting an LVAD if they need it. So that's been helpful. And after this study came out, MITRACLIP gained FDA approval in March of 2019 for symptomatic moderate to severe functional MR despite optimal medical therapy. But I will discuss here that there were 2 studies actually that looked at this, and you know, just to have a little bit of history here for the applicants who may or may not know this, but MITRA-FR actually came out first, and I remember when it came out because you can see here that there was no difference in the 2 groups, MITRACLIP versus placebo or versus medical therapy versus COAPT, that did show a significant improvement in outcomes. And when this came out, when MITRA-FR came out, I remember there were a lot of physicians who said, well, that's what we expected. You know, we didn't think that clipping the valve was actually going to help with the, you know, LV problem that's going on here. And then thereafter, a couple months later, COAPT came out. And so why such a difference? You know, for a long time, for a while, actually, after these came out, people said, well, I think we're going to need a tiebreaker. I don't know that we can just, you know, get this approved. But there were subsequent analyses, many analyses that happened after. And in comparing these 2 studies, there was a much more rigorous guideline-directed medical therapy titration protocol in COAPT. There was a central eligibility committee that included a heart failure specialist and a mitral valve surgeon on weekly calls. And there was the heart team, which is really important. I want to emphasize that because that's really an important piece to all of this and all these heart failure therapies. Is that it includes a heart failure specialist, interventional cardiologist, cardiothoracic surgeon. So you need a team of people really to discuss, you know, the right thing to do here. And imaging specialists as well, I would say should be included in these decisions. And so with these calls, you know, there were very you know, tiny titration and really nitpicky titrations, like, no, let's go up on the beta blocker a little bit more. Let's go up on the ACE inhibitor a little bit more. And so it did take quite a long time for patients, for the study to be completed. But I think it was the right thing to do because, you know, they wanted to make sure that patients were on the optimal guideline-directed medical therapy prior to, you know, assessment of whether or not they should get this device. And with MITRA-FR, patients had to be on guideline-directed medical therapy, but there was no specific titration protocol. And so they just had to be a checkbox that they were on it. And so, as you can imagine, they may not have been on the optimal doses that they needed. There were also less procedural complications, possibly more experience in the COAPT trial and less residual MR. So there may have been some procedural reasons that there was more benefit. But probably the most important point here, and I want to, and it kind of goes back to the guideline-directed medical therapy titration as well, so I want to talk about this piece here. And so if you look at this diagram here on the right, you can see that the COAPT population had these ventricles and this MR, and the MITRA-FR had these ventricles and this MR. And so the idea here being, if you have more MR with less dilation, albeit with dilation, you'll probably benefit more from MITRACLIP than if you had less MR with a lot more dilation. And that brings us to this idea of proportionate versus disproportionate functional mitral regurgitation. You know, if you think about LV dilation and mitral annulus dilation, there's going to be a degree of non-coaptation and mitral regurgitation that occurs. And so if you have that dilation and mitral regurgitation, there's going to be a proportionate degree of mitral regurgitation that occurs. But if the mitral regurgitation then goes beyond that and is now disproportionate, as in the COAPT trial here, then those are the patients who actually may benefit more than the patients who have, you know, a 9-centimeter ventricle with 3+ MR, whereas a patient who has maybe a 6-centimeter ventricle with 4+ MR, if that makes sense. So as the MR is worse than the LV dilation, then those are the patients who are probably going to benefit more in this population. And this these points actually are interesting because if we think about LVAD therapy, which I'll talk about a little bit in the coming slides, but LVAD therapy is supposed to unload the ventricle and improve LV dilation as well, and improve and cause reverse remodeling. And so currently the guidelines are that even if you have severe MR and you're going to put an LVAD in a patient, you don't fix the valve, the idea being that the mitral valve regurgitation should improve with LVAD therapy. But there are a population of patients that have residual mitral regurgitation despite adequate unloading with the LVAD. And so then the question is, well, what about those patients, and what happens to their outcomes, and what happens to their right? Do they have increased? There's some signal for right heart failure in those patients, and possibly worsening outcomes. And so that's actually what my research project is looking at, using multiple LVAD databases from different institutions, is looking at pre and post mitral regurgitation and as it relates to outcomes, specifically right heart failure in these patients. And then the question that our group is interested in possibly pursuing as well is, well, where does MitralClip come into play here? Are the patients who get MitralClip before they get an LVAD? So first of all, you know, can we predict whether or not those patients, which patients are the ones who are going to so-called fail MitralClip therapy and need an LVAD? And further, does the MitralClip before LVAD help improve the residual MR and possibly outcomes in terms of right heart failure and maybe mortality as well? I'm going to shift gears to the, so we kind of left the interventional and cardiothoracic surgery world and go over to the EP world that we partner with as well. And I'm going to talk about this new device, which is the Optimizer Smart System. It's using cardiac contractility modulation. And some of you may have heard of it. I assume many have not, because a lot of people have said to me that this is new to them. But this actually is a therapy. I'll say that we implanted our first one. Dr. Wax actually implanted the first one at BI a couple weeks ago on a patient that Dr. Kramer and Dr. Wax and I share. And what it is it's actually implanted similar to a pacemaker. So it's this device here on the right. There's a generator that's implanted subcutaneously. There are electrodes that are put in, and you know, specifically deliver non-excitatory electrical signals to the RV septum during the absolute refractory period. So if you look down here in this diagram here, the idea here is you want to prolong the action potential duration and potentiate systole. So you're delivering this signal on, you know, in the absolute refractory period, but never on top of the T wave. And what's been found is that early on, there's improvement in calcium handling in the cardiac cells by upregulation of circa 2A and augmentation of LV contractile strength without an increase in myocardial oxygen consumption. And long-term effects are actually quite interesting. So there's this reversal of the fetal gene program. So what I mean by that is what happens in heart failure is that patients start to go from the adult gene program to the fetal gene program in terms of their calcium handling. So the genes that code for proteins that cycle calcium actually are downregulated, and that's the fetal gene program basically that happens, and that can make things worse in terms of remodeling and contractile strength. And what this therapy actually has been found to do, which is quite interesting, is reversal of that to the adult program. So there are actual changes in mRNA that code for these proteins, and an increase in the mRNA that code for the proteins that handles calcium cycling. And so there's that change actually in the genetic aspect. And further decreases cardiac fibrosis and remodeling from those changes. And what's been found is that this first happens in the tissues right near the electrodes initially, but then it starts to spread out to the rest of the myocardium. So the benefits here in a randomized trial, the CCM actually was associated with some clinical benefits, including improvement in exercise capacity as measured by peak VO2, 6-minute walk distance, quality of life measurements, and symptoms. And in addition, actually found a reduction in the composite of cardiovascular death and heart failure hospitalizations at 6 months of follow-up. So because of these findings, the FDA approved this device in March of 2019 as an expedited access pathway. And this basically occurred because this is an unmet need patient population. So it was expedited. And this patient population includes patients with HFrEF, but also this HFmrEF, middle range EF, so 25 to 45%, who are not eligible for a CRT, so their QRS duration is shorter than 130 milliseconds. They have NYHA class 3 to 4 symptoms despite optimal guideline-directed medical therapy, and they're not eligible or maybe not sick enough for an LVAD. But when all else fails, you have our advanced therapy options, and that's where we can be very helpful as well. So heart transplantation and LVAD therapy. The LVADs that we have available are all continuous flow LVADs. Here are the images below. The HeartMate 2 is basically becoming obsolete. We're not putting them in anymore, but the patients who had them continue to have them, so you may encounter them still. The HeartWare device here and the HeartMate 3. The HeartMate 3 is really our go-to device as it is as imaged here. This is a device that has a rotor that's magnetically levitated. It's bearingless, has wide passages. So all these, and has an intrinsic pulse, and all of these things reduce stasis and decrease the risk of thrombosis. And that was found in the Momentum 3 trial that looked at this device in comparison to its predecessor, HeartMate 2, and found a very significant improvement in survival as well as freedom from pump exchange due to thrombosis. And so because of the compelling data that this device really has a very, very low thrombosis rate, and even, in fact, patients can be off of aspirin and on lower doses of Coumadin with INRs that are lower, especially if they're having GI bleeds. This is the reason that this is our go-to LVAD now. And in fact, there was recent data from the Elevate study and the LAT feasibility study that found that a lateral thoracotomy approach is associated with less bleeding, infections, and arrhythmias. And so as of January of 2020, this device has been FDA approved for implantation as a lateral thoracotomy approach, which can be nice in patients who have maybe had several sternotomies in the past due to coronary disease or valvular disease. The future is bright in heart failure, and there's a lot of cool new devices that are being studied, including fully implantable LVADs. This would be something without a drive line, with transcutaneous energy transfer. Several of the VAD companies are actually currently studying these devices and trying to develop them. The implantable long-term intra-aortic balloon pump, which is a device that is actually literally a balloon pump that you put in and have a drive line, and you get to, with batteries, and you go home with this device for long-term therapy. And we're actually in discussions with that group about, this is the IVAS therapy, in discussions about being involved in their pivotal trial. The percutaneous ventricular repair system in patients with functional MR. This is the AccuCinch system, which we'll be starting to study here as well. Stem cell therapy is ongoing throughout the country and internationally. Vagal nerve stimulation is being looked at in the Anthem study, which we're trying to bring here as well. So stimulating the vagal nerve as there's this disproportionate revving up of the sympathetic and a decrease in parasympathetic activation in patients with heart failure. So if we turn that around and increase vagal nerve stimulation, will that help heart failure patients? A robotic sleeve, which is a soft sleeve that fits around the heart and helps it beat, is being actually studied right now in Boston hospitals as well as 3D printed heart tissue. So there's a lot of interesting new things, and I hope that when giving this talk in the future, we'll be able to talk about some of these things again. So this question also we don't have to do a poll for, but I just want to emphasize a point here. But which of the following patients would you refer for advanced heart failure therapies? The first one is an 80-year-old man with severe PAD end-stage renal disease on hemodialysis, ischemic cardiomyopathy with an EF of 35% on guideline-directed medical therapy with class 2 symptoms, a 72-year-old man with ischemic cardiomyopathy and EF of 20% with class 3 symptoms on guideline-directed medical therapy. The third one is a 42-year-old female with non-ischemic cardiomyopathy, severe MR, EF of 30 with class 3 symptoms on guideline-directed medical therapy. And finally, a 20-year-old man with non-ischemic cardiomyopathy, a history of IV drug use, possibly recent, unclear, class 4 symptoms and inability to tolerate guideline-directed medical therapy. And I would argue that, honestly, all three of the bottom ones here, we should be referred for advanced therapies. You know, patient A, we're happy to see anyone, honestly. So we will see any patient that you want to refer to us. But the first patient here is, you know, it has an age that precludes transplantation, has comorbidities that would preclude a destination therapy VAD, including the end-stage renal disease and PAD, and frankly is probably doing pretty well, you know, class 2 symptoms, so not really sick enough to need these therapies. But the other patients here are all pretty high risk, and patients that we would like to see and would like to help discuss what the next best steps for these patients are. Even the patient with the history of IV drug use, this is a very sick patient I'm describing who's 20, and we may be able to work with social work, palliative care, psychiatry, etc., addiction specialists, and maybe how, you know, turn this around. It doesn't always work, but, you know, it's worth looking into. So when should you consider advanced therapy referrals? So these are the poor prognostic markers, class 3 to 4 symptoms despite medical therapy, recurrent heart failure admissions, persistent hyponatremia or worsening renal function, an inability to tolerate their neurohormonal blockade agents, increasing diuretic requirements. And then I do want to put a plug in here for cardiopulmonary exercise testing. So a peak VO2 less than 14 is a criteria for transplant listing or DT-LVAD. And, you know, I have told many other cardiologists this as well, is if you have a patient with HFrEF, just get a cardiopulmonary exercise test, even if it's just a baseline test. If the patient tells you that they're asymptomatic, that's great, and maybe they are, but it's really good to have that prognostic information, number one, so you can guide therapy with them and discussions with them, as well as to have objective information with the subjective information they're giving you. You'd be surprised how much patients have changed their way of life in order to have no symptoms, but really are quite debilitated. And this slide, I won't go into too much detail, but these are the intermax levels that we use to classify patients who are getting LVAD therapy. And suffice it to say that 1 is the worst, crashing and burning patient coming in hot on VT storm, needing ECMO, and 7 is an ambulatory patient with class 3 symptoms. And we want to catch patients in this 3 to 4 range. So the patients who go into LVAD therapy here have worse outcomes. Patients who go in here do much better. And so bottom line is it's never too early to refer, but it can be too late, unfortunately. And we do this we do this as a team. It's a patient-centered shared care system. The patient and the caregivers and the loved ones are at the center here. They're what we're doing this for. And then we have a heart team that includes the heart failure physician, but also the interventional team, the electrophysiology team, the cardiothoracic surgery team, and imaging specialists, as well as all the other specialists who help us, including ID, palliative care, social work, pharmacy, physical therapy, nutrition, all come together to take care of this patient and give them holistic care and make sure that they're getting their goals of care addressed when we're discussing advanced therapies. So I'd like to just take a minute here. I know I'm running out of time, but I'd like to take a minute just to talk to the applicants about what we have to offer here at BIDMC in terms of heart failure during general fellowship. So in general fellowship, you have the opportunity and you will rotate on the inpatient heart failure rotation, and you will have the opportunity to see patients with Impella CP, 5.0, RP, and soon to come is the ProTech Duo, which is a percutaneous RBAD device that we're about to start implanting as well. Patients with VV and VA ECMO, as well as patients with durable LVADs and heart transplantation who may be admitted for various reasons, including infections or rejection. There are opportunities to join in the ambulatory heart failure clinics. We have specialty clinics in cardio-oncology, sarcoidosis, amyloidosis, genetic cardiology, and soon to come is a clinic in hypertrophic cardiomyopathy, as well as the ability to participate in level 1 and 3 CPETs. Because we do all the pre and post-transplant care here at BIDMC, but the actual surgery, transplant surgery occurs at Tufts Medical Center, and we partner with them. And so there is a 2-week inpatient rotation in heart failure at Tufts Medical Center, just to have the opportunity to see those patients who are coming out of transplant in the acute setting. And we do have a combined BIDMC Tufts Advanced Heart Failure Fellowship. There is in terms of education, there is a fantastic shock course at the BIDMC Simulation Center. Shout out to the group who's there right now, because I think they're about to start in a couple minutes. This is run by Dr. Grandin and really spearheaded by him, and then all the physicians and nurses in the heart failure group participate in that. And I think it's been really a lot of fun and a great educational experience for the fellows. And then finally, there are multiple research opportunities with the heart failure team and the Smith Center. And so I'm just going to show this here just so that you have a sense, but we're involved in many national, international databases. We have access to these databases and are doing multiple studies with several residents and fellows, as well as BIDMC homegrown databases, including several databases here. I mentioned LVAD, SHOCK, MCS, as well as an MCS biorepository, which our former fellow Dan Katz and Dr. Gersten have been very helpful with in terms of for studying these patients and doing some proteomic work on them, hopefully soon. And also many national multi-center studies that we are site PIs for. I mentioned Pioneer HF. We are also about to start AccuSynge and Pulse Paraglide, a couple other studies that are looking at some of these medications in HFpEF, and also some of these. Anthem is the vagal nerve stimulator. AccuSynge is the one that's looking at functional mitral regurgitation, the device that goes in for that. So a lot of exciting new things happening here. And in addition, we have a weekly research meeting that we have every week that includes the heart failure team, a statistician, and research assistants, really to push along. We start from brainstorming studies to pushing along to abstract submission, as well as manuscript completion. This is our heart failure team of physicians, and really this is our family. So we have, we would be nothing without our administrative coordinator, our AAs, our pharmacists, our nurses, amazing team of nurses and NPs for heart failure and LVAD. And these are pictures here of us. We work hard, we play hard. This is some of these are outside of the hospital, our kids playing together. And one piece of advice I would give to the candidates is, when you're looking for a fellowship and when you're looking for a job, look for something, a place that's going to satisfy your research and clinical interests, of course, because that's going to really determine your job satisfaction. But a really important piece, I would say, is look for a group of people that you enjoy working with. When you wake up every morning and come to work, you want to be with a group of people that you actually enjoy interacting with every day, and really feel that you're part of a family and not just a clinical group. So with that, I will take questions, and good luck to the applicants today with your interviews.
Thank you so much, Marwa, for that really terrific talk. While folks are coming off of mute and getting ready to ask questions directly, I do have one question on the chat from Dr. Warren Manning. He asks, is there a role for advanced imaging modalities such as cardiac MR for assessment of fibrosis, late gadolinium enhancement, or native T1 or ECV to identify patients more likely to benefit from one or more of these pharmacologic or mechanical therapies?
That's a great question. And I have to say, I don't know how much that has been looked into. There have been studies that have looked at looking at fibrosis and LGE to see whether or not it's helpful in determining the type of heart failure, if it's a non-ischemic heart failure type of heart failure. But in terms of whether or not a patient will benefit from one of these new medications, I don't know that that's actually been looked into, but it's a great question.
Wonderful. So we have time for probably one more question. If anyone wants to send anything on the chat or come off mute.
Hi, it's Rashad. I have a quick question, Marwa. That was fantastic. Thank you. You sort of highlighted really the therapies, both medical therapy and device-based therapy, that are filling in kind of that gap that has existed for a long time, between the patient who's stable on medical therapy and then all the way to, heart replacement therapy. And you sort of highlighted the INTERMAX profiles as, the INTERMAX 3 patient that's kind of the sweet spot for LVAD implantation. Do you think, what do you think we'll get to a place where the sweet spot really becomes, some of what we consider traditionally the more stable INTERMAX profiles? So still advanced heart failure patients, but people that we do still see they slip through the cracks and show up, in such bad shape that they're not a candidate anymore. And what are the things in our field that you think have to happen with LVAD therapy to push the bar that way?
That's a great question, Rashad. And, one of the things that I kind of quickly mentioned, but is that we want more objective information to go along with the subjective information. So again, the INTERMAX levels are really based on, a lot of it's based on symptoms. And, of course, there's some information in there as well in terms of, needing mechanical support or inotropes. So stable class 3 or a stable INTERMAX level 3 patient is someone who's on inotropes. So, they had to have had some invasive testing at that point. But if you go through the later levels, as you mentioned, 4 through 7, those are mostly symptoms. And so I think it's really important to catch patients, as I said, catch patients early, get the objective information, get that cardiopulmonary exercise test, even if a patient is telling you they're completely asymptomatic, because it does give you some more information about what they're really doing, what's their true oxygen consumption, possibly consider a right heart cath in certain patients. And then I think that will move the bar a little bit, because I think there is that place, between 3 and 4 where you're like, well, what's the sweet spot there? Is, what's the difference between a patient who's 4 and a patient who's 3, and maybe even a patient who's 5? Again, it might be that the patient is just compensating on their own in terms of just decreasing their amount of workload. I'll never forget a patient that I met early on as an attending here, who we literally measured her FIC. We measured it. We didn't actually calculate it. We measured her FIC to be an index of 1.0. And that day when I went to see her in the inpatient setting, she said, "Today's the best I've ever felt." And so there's a big discrepancy in terms of how patients feel and what is actually maybe going on. And so early referral, like I said, if there's any question, or even just a question for the advanced heart failure physicians about the studies that they've had, can really help us get to a patient before they're at the point where they're crashing and burning, or they now have multiple organs involved and too late for those patients.
That's wonderful. Well, thank you so much, Marwa. To get everyone out in time for their interviews, we'll wrap it up here. Thank you, and we'll see everyone next week.
Thank you.